welcome everyone to today's webinar, April already. Today we have joining us Dr Lara Roeske, who is a member of the Cancer Council Australia Cervical Cancer Screening Guidelines Working Party and a co-author of the 2016 National Cervical Screening Program, Guidelines for the Management of Screen-Detected Abnormalities, Screening in Specific Populations and Investigation of Abnormal Vaginal Bleeding. Lara is also Director of Education and Liaison at VCS and has extensive experience in translating cervical screening and HPV evidence into clinical practice. And as well as all of that, she's also a very busy GP. We also have Dr Tony Lemke, who is the Chair of qiCommunity, an expert in all things QI, and works at Alstonville practice in North Coast, New South Wales. So welcome, Lara and Tony. Thank you so much for joining us today.
Thanks, Sarah.
Thank you very much, Sarah, and welcome everybody joining us online from all over Australia. And Lara, thank you very much for joining us today. I'm in Alstonville, which is, as always, beautiful and sunny and quite warm. I think most of Australia is at the moment, and we think of those people affected by bushfires. And Lara, where are you today?
I'm in Melbourne and it's overcast, Tony.
Oh, that makes us very sad to hear that when it's rainy in Melbourne or Sydney. The rest of us are happy, I'm afraid to say. Lara, tell us about the renewed cervical screening program. What's happening?
Okay, well, Tony, very exciting times. We have a brand new program, and of course it's absolutely important for GPs across it because it's GPs and their teams which will implement the new program and will play a vital role in its success. And to date, we've known they are the contributors to the success of our previous pap smear-based program. So I'd like, I perhaps would like to just say that the renewed program is for HPV vaccinated and unvaccinated women who are asymptomatic, aged 25 to 74, who've ever been sexually active. But the new guidelines also provide advice about the investigation of symptomatic women, and we'll talk about that later today, and includes the provision of an alternative self-collection pathway for eligible women, and we'll talk about that as well. Next slide.
So, Lara, the new guidelines then, which are available to download on the link that you've provided, one of the key features I've noticed already is that the age has gone from 20 up to 25 and from 70 up to 74. That's a change, isn't it?
Yes, that's a big change. And just before we look at those specific changes, and we're going to summarise those, I just wanted to point out that the guidelines came into effect. So we actually are operating now under new guidelines. They came into effect on the 1st of December. They are endorsed by the RACGP as clinical guidelines for general practice. They can be accessed by the link on that slide, and they are a wiki interactive platform. So you can hover over a chapter and it'll take you straight there. Particularly chapters I'd like to recommend that GPs do take a good look at would be chapters 1 for cervical cancer overview, chapter 2 for the rationale for HPV testing, chapter 6 for the management of oncogenic HPV results, chapter 13, hysterectomy, and chapter 18, which deals with the investigation of abnormal vaginal bleeding. So 1 to 6, 13 and 18 are great chapters for bedtime reading.
1, 2, 6, 13 and 18. We will put that by our bedside table tonight. So the new program focuses not on cytology so much, but on HPV-based screening. Why are we doing that? What's the story, Lara?
Yes, no, that's a great question. That's because it's a newer, more sensitive approach to cervical screening. So we're actually testing for the presence of the causal agent for cervical cancer, human papillomavirus. And what this actually is going to mean is a lot less intensive testing for women. Women are now going to experience on average 10 rather than 26 cervical screening episodes in a lifetime. The main messages for women are that the new program will deliver better health outcomes with less intensive testing, but is just as safe as the current program. It will protect up to 30% more women from cervical cancer, and certainly model evaluations performed by MSAC estimate further significant reductions both in incidence and mortality from cervical cancer from between 24 to 36% when we compare it with the previous 2 yearly pap smear-based screening program. So great news, great reassurance, and great news for women.
It's an important message that it's more effective than what we've used previously, but less invasive, or less frequent anyway, than what we've used previously. That's a great message. So the main features then, Lara.
Yes. So this slide on your screen summarises those. We're going to start screening later at age 25. We're going to have a longer screening interval of 5 years. We're going to exit between 70 to 74 years. So that's a later exit age, and that applies to all women who are asymptomatic, who've been screened up to the age of 69, who have a negative screening history. Those women will be eligible to be offered a one-off CST between cervical screening tests, I should qualify, between 70 to 74, and if that is negative, they may exit. Of course, should a woman present to a practitioner after the age of 74, so at 75 or 76, and should she ask for a cervical screening test, then that will be funded and certainly is recommended in women with either no cervical screening history or a patchy cervical screening history. A couple of other changes are terminology-based changes and also the testing platform and the test changes. So we're going to test as a primary screening test for 14 oncogenic HPV types. That also incorporates partial HPV genotyping, specifically identifying type 16 and 18. We'll talk about that later. And our test is now going to be replaced with the term cervical screening test. And actually, for the interest of the audience, this was what women wanted the new pap smear to be known as. So large forums of women elected the term cervical screening test. And finally, of course, all samples in which oncogenic HPV is detected will have reflex liquid-based cytology, and we'll talk a bit more about that as well.
So out with the pap smear, in with the CST.
In with the CSTs. There are just a couple of other main changes or inclusions in the new guidelines, Tony. One is that symptomatic women, and those women particularly that have symptoms or possible symptoms of cervical cancer, namely bleeding, discharge and dyspareunia, and that's what I mean by pain there on the slide, can actually be tested at any age, whether they're under 25 or over 74. In this situation, a co-test will need to be requested, and this is in line with diagnostic testing and not part of routine screening. There's also provision for women who are found, perhaps at the time of the consultation, may reveal to the doctor that they actually have experienced sexual activity or early onset of sexual activity prior to the age of 14 and prior to HPV vaccination. There is provision for and funding for a one-off single cervical screening test between the age of 20 to 24 years. So that is one situation where you may offer, and the women will be eligible and funded to have a CST prior to the age of 25. If women are symptomatic or they actually have early onset sexual activity.
Laura, I've seen a cervical screening pathway, and I'm sure it must be simpler in practice than it looks on the paper. Perhaps you could talk to us about that.
Yes, I'll just highlight very quickly the key features of the pathway. To the far left in green, these are women who are found to have no oncogenic HPV detected in their cervical sample. These women will be invited to rescreen in 5 years, at which time the clinician should order a CST, a cervical screening test. To the far right, in blue, we have unsatisfactory HPV tests, or indeed unsatisfactory reflex liquid-based cytology. We'll talk about those in a moment, but these tests need to be repeated. So a repeat test needs to be requested, preferably within 6 weeks, but up to 3 months is fine. Again, on the far right, second in red, are those women who have the higher risk oncogenic HPV types detected, type 16 and or 18. All women with 16 and or 18 HPV detected require referral for colposcopy, irrespective of any reflex cytology result. And in the middle, in the orange and the yellow, are the most fascinating group of women, and these are women who actually have other oncogenic HPV types detected, not 16 or 18. And this is an interesting group because these women will be triaged according to the reflex liquid-based cytology results. So that if the reflex cytology result, and incidentally that test is done automatically on the sample that has been sent in. So the clinician, the doctor, does not need to order the test specifically. It will happen if oncogenic HPV is detected. So in that middle intermediate group who are found to have oncogenic HPV types not 16-18, if their reflex cytology is negative, low grade or possible low grade, and that's what the little P means on the slide, these women need to return for a repeat test in 12 months looking for clearance of the HPV. And in those women who have either possible high grade or a glandular abnormality on their reflex cytology, those women will require referral for colposcopy. So we can see that within that middle group, there will be streaming of women, and hence the colour change on the pathway from orange to red if they need to go for colposcopy, or down the yellow to a repeat test, and if that is negative, they then will return to 5 years and be asked to rescreen with a CST.
Okay, that's clear, and I know you'll go over some of these features as we go along. So we're testing, we're not looking at the cells each time now, we're looking for the HPV presence or absence of that, because that's a more effective way, because you can't get cervical cancer unless you've got HPV, and looking for the HPV is more effective. Is that what we understand?
Yes, Tony, that's a really good way of putting it. And look, I don't want to apologise. I think I needed to include two graphs today. This is the first one, and this one's very important because it tells us why the 5-year screening interval is really quite safe and appropriate. And it has to do with the sensitivity of the HPV-based screening test and also its negative protective effect, which actually then determines how long women can go away for before they need to come back for another screening test. So if we look at this, and this is Dillner's meta-analysis, which was published in the British Medical Journal in 2008, this graph actually underpins the evidence for the new screening program, and that's why I've included it. And I want doctors and their teams to be confident about understanding why going away for 5 years after a negative HPV means that you're in safer, if not safer hands than were you to come every 2 years with a pap smear. So let's look at time zero, and we're looking really at the incidence of CIN3+ on the vertical axis in hundreds and thousands of women over time, following on from a baseline negative pap smear. That's the blue line. And if we go out along the horizontal to 24 months, and I think if you press next slide, you'll get an arrow up now, Sarah. Yep. You'll see that if you had 1,000 patients with a negative pap at time zero, in 2 years, 4 out of those 1,000 of your patients will actually have CIN3 or worse on their result. And that's as good as our cervical screening test was, the pap smear-based test. And that was why we were needing to bring women back about every 2 to 3 years. If we go out to 36 months and you press yep, you'll see that 5 out of 1,000 of your patients now will have either CIN3 or worse on their next screening test. However, if we go out to 72 months, 6 years, and we follow that red dotted line, which is a woman, thousands of women starting with a negative HPV at time zero, we can see that 3 of 1,000 will have a similar CIN3 or worse lesion. So in fact, the HPV test is outperforming the pap smear at 2 and 3 years, which is the screening interval for the pap smear, all the way out to 6 years. And 6 years was actually initially proposed as the screening interval. However, it makes much more sense to screen women every 5 years. So at 25, 30, 35 rather than 25, 31, 37, etc. And so we've adopted in Australia a 5-year screening interval. So that's the first figure I wanted to show you, Tony.
I'm convinced.
Right, I'm glad. And yep, this is the next figure, and this one's quite important as well. This is looking at something a little bit different. We're looking at women who are now starting out HPV positive at the baseline, and we're looking at their cumulative incidence rate of developing cervical precancer, which is known as CIN3 effectively, or plus or worse, over a 10-year period. And we can find that what HPV type you start out with is significant in terms of determining your risk of developing cervical precancer over a 10-year period. And if we follow the very top line, and these are women who are initially positive for HPV type 16, we find that these women are at significantly higher risk of developing CIN3 or worse. And in fact, we can quantify that for you, and we can tell you that that risk sits at about 17%. So about 17% over 10 years with a HPV 16 positive at baseline will be at risk of developing cervical precancer. The next line along represents those women who start out HPV 18 positive. And the risk for them is a little bit lower, but it's still deemed high risk, and it's about 11%. In comparison, however, the risk for women who may start out with any of the other oncogenic HPV types is lower and sits at around 3%. And of course, it is extremely low for those who have no oncogenic HPV at baseline. And the reason why I've shown this figure, Tony, is that it follows on to the next slide, actually, which is a new feature of this screening program, and that is your pathology results should actually include an overall cervical screening risk assessment for the individual woman. And women will be assigned, and it's a bit like the traffic lights, red, orangey, yellow, green, low, high risk or intermediate risk. And that assignment will take into account three things. Takes into account, in fact, the cervical screening history. And that's why the National Cancer Screening Register is very important, and the state and territory-based registers that are still working to support that national register. So that is taken into account in determining the risk assignment to the woman. What the clinician writes on the pathology request form, any clinical notes, and also, of course, the CST results, inclusive of any reflex liquid-based cytology. So women participating in the new program will be allocated an overall risk-based assessment as part of their results.
And so what we write on the pathology form may include intermenstrual bleeding or previous history, or is that the okay?
Certainly.
So we either mark it as routine, which is asymptomatic, or symptomatic, and they take that into account when they do the traffic lights.
Absolutely, and most laboratories, and certainly we reconcile the past cervical screening history also with what is in the clinical notes on the pathology request form and what the results are of the CST and in reflex liquid-based cytology.
Lara, I will fill that form out more accurately in future.
No, that's great. That's great, Tony, and a great endorsement of doing so. Thank you.
We might talk a bit more about the mechanics of the test then, Lara, what we actually do and what it is.
Yes. So what is the CST compared to a pap smear? And that's a question we often get asked. So a CST is really, at first, a nucleic acid test. And it could be PCR or RNA based, but it basically is looking to detect the genetic material of 14 oncogenic HPV types found in cervical cells that are suspended in that liquid medium. So in the vial that you can see there, the SynPrep vial, or SurePath is the other vial that is commonly, well, less commonly used. About 1 in 10 GPs are using SurePath currently. The new cervical screening test includes HPV genotyping, and I've mentioned already that you will receive specific identification of 16, type 16 and 18, known to cause up to 70 to 80%, it sits close to around 77% actually, of cervical cancer in Australia. So the highest risk types will be specifically identified. The other 12 oncogenic HPV types will be grouped together as oncogenic HPV non-16, 18. And of course, automatically, where oncogenic HPV is detected, reflex liquid-based cytology will be run by the lab and reported to you.
So to take the test, Lara, it's very similar from the woman's point of view to having the traditional pap smear, unfortunately, I guess, from her point of view. No one comes in wanting a pap smear.
Yeah, so exactly. We actually say that you should take the test, collect the sample exactly in the same way as you've always done. We can go to the next slide, actually. And you do need to insert a speculum to visualise the cervix. You should use the sampling instruments that you've always used and been comfortable using. The cervical sample will be placed directly into a liquid-based medium, and there will be absolutely no need to make a slide, and there'll be really no facility, no funding for slides. So please don't send slides to your lab. When you're rinsing the sampling instruments into the vial, they need to be rinsed very thoroughly, and we do have a video of this on our website. I'm actually unfortunately on that video, but you can see it's a bit like a MasterChef cooking class. Really 10 rotations of your sampling device through the liquid, pressing up against the sides and the bottom of the vial to release as much cellular material from the cervix into the vial, and the sampling instruments should then be discarded, certainly for the thin prep medium. And by the way, these vials are known as thin prep or TP. They can be known as SurePath. They can be known as liquid-based cytology or liquid-based samples. All those words mean the same thing. Please ensure the vial is labelled correctly. There should be 3 identifiers on that vial: a surname, a given name, and a date of birth. Check the expiry date. The vials do include a little black dot on the cap and on the body of the vial, and those dots should oppose or cross, so that when you actually close the vial and seal it off, it's sealed appropriately and doesn't leak during transportation. And I'd say we can move on to the next slide.
Well, I've just done one, Lara, and I've got it sitting right in front of me, and I hadn't got those black dots aligned, so I have now. I've labelled it. I banged it on the bottom 10 times, which is what I was told, but I should have knocked it against the sides a bit more to rinse it by what you're saying.
Tony, that really helps, and when you do that, and if you do get to watch our video, you can see how it really opens up the bristles and pushes them apart quite effectively. So thanks for doing that.
Okay.
A couple of other pointers. Some of the doctors often wonder whether it's still important to sample from the transformation zone, and hence you have these very illustrative pictures before you. Definitely. Sampling from the transformation zone is important. It optimises the sensitivity of the HPV test. It also is very critical for any subsequent reflex liquid-based cytology test, because we still need cells to run cytology to look at should oncogenic HPV be detected. So the pictures of the cervices are just to remind GPs that the cervix looks whitish where we have the ectocervix or the squamous columnar cells. They are the multi-layer squamous cells. There is then a transformation area where the columnar cells, which you can see is a little red flush on the left cervix, and out on the surface of the cervix, actually, they are single-layer glandular columnar cells. They are underlain by a rich vascular network, and when you shine a light on them, that's why they look so red. In the left slide, if you focus around that cervical os, you'll do well. You'll pick up a pretty good cell sample. On the right-hand slide, however, if you focus on the cervical os, you'll actually miss the money. You'll get a great columnar cell sample or glandular cell sample, but you won't have any squamous cells. They're important. So that's a reminder for GPs to take their sampling devices right to the periphery of that red eversion or ectropion or erosion, as it's known, and go all the way around so that you're picking up cells at the junction between the whitish squamous area and the red glandular area. I've also wanted to highlight that unsatisfactory results are going to occur a lot less frequently, which is great news with this new HPV-based screening. In fact, it'll be 20 times lower, and I've just quoted there for you. We get about 2 to 3% unsatisfactories with the pap smear-based program, and that'll drop right down low. So a lot less women being asked to come back to retest or repeat a test at 6 weeks. This is a picture of what some slides look like, and you can see they can look pretty messy. On the right, that is a dense inflammatory exudate. Can be quite a common finding in the cervix. Doesn't necessarily link in with the presence of a true infection, but makes it really hard for a cytologist to read any of those squamous cells. They're totally obscured. And that's why this new liquid-based medium, where the cells are floating in the liquid and we're relying mainly on PCR-based testing, is going to get rid of a lot of the difficulties we've had with unsatisfactories and interpretation. Now, I also wanted to point out how many cells we need in there, Tony. So I hear that you've been pretty diligent. We need about 5,000 cells inside that vial to do reflex-based cytology and about 1,500 cells to run the HPV. We know that in 90% of unsatisfactories with the new HPV-based testing method, the reason is insufficient cells inside that vial. And a lot of that has to do with the way we're transferring the cells into the vial. It's not a good time to take a shortcut. I know we're all excited about not having to use fixative anymore, but we need to make up that time by spending more time in the vial transferring the cells. Please also note that about 10% of unsatisfactories are due to inappropriate, incorrect use of lubricants, which brings me to the next slide. So the lubricants have come to the fore. They are very important in this renewed program. They have the potential to interfere with the quality of the cervical screening test, both by blocking the acquisition of cells from the biosampling devices from the surface of the cervix, and they can also interfere with molecular-based testing. So they must be water-soluble, carbon-free. They should be used very sparingly and just applied to the outer part of the speculum, taking great care to avoid the tip. I've listed on the next slide lubricants which are approved for use, and please note L-Gel and Applicare are not okay. In fact, lukewarm water to lubricate the speculum does present the least risk to the quality of the cervical sample. However, if you're like me and you sort of always use lubricants, it's hard to go back to water. So please make sure that your practice and importantly your room is stocked with an approved lubricant. We can move on to the next slide. Just noting here what you need to indicate on the form. These are an example of our forms, and we've actually given our doctors who use us a clear choice of what they should be requesting with the new terminology. So for asymptomatic women 25 to 74 in routine screening, you're going to tick CST or all right cervical screening test. We've noticed some of the software is auto-populating HPV and LBC. That is really incorrect and inappropriate, and until that changes, we're asking clinicians to just check what is coming out of your printer and ensure that you're ordering a CST when you should be, or a co-test, because sending HPV and LBC to the lab may incur a charge that a woman isn't expecting and that you're not expecting as well. Next slide. Tony, I'm wanting to move on to co-testing now and investigation of symptomatic women.
Thank you.
Yep, great. Please stop me. I'm conscious of time, so I'll keep going.
We'll run through this bit quickly, Lara, because
yes,
that'll be fine.
yes.
Thank you.
Yes, great. So just the co-test is two tests, the HPV test and the LBC. These are the four reasons why a GP might be ordering a co-test: the investigation of abnormal bleeding as part of test of cure when you're following up a high-grade abnormality that's been treated and biopsy proven. In certain situations, when you're doing vaginal sampling post-hysterectomy, a co-test is appropriate, and Chapter 13 illustrates that further. And in DES or diethyl exposed women who should really have an annual co-test and colposcopic vaginal surveillance. They're a small subgroup of women, and some of you may not be aware of their existence. There is a chapter in the guidelines that covers that. It's a brief one. Next slide. This is acknowledging that our new guidelines do provide guidance for us for the first time about investigating women with abnormal vaginal bleeding. And on the next slide, there's some key pointers about that. to assist, following slide. That's a picture of a cancer. That's what we're trying to avoid. If we could go to the next slide. So women at any age with abnormal vaginal bleeding, and that includes postcoital bleeding, unexplained or persistent intermenstrual bleeding, any postmenopausal bleeding should have a co-test. And if bleeding is unexplained intermenstrual or any postmenopausal bleeding, they also require referral for gynecological assessment. I've included the recommendation there, and we can move to the next slide. So that's what you're going to select on your request form, a co-test, and under clinical notes, you may choose to write PCB, PMB, postmenopausal bleeding, postcoital bleeding. You may choose to write persistent or unexplained IMB, intermenstrual bleeding, or you may tick where appropriate to the far right and select abnormal bleeding or make notes. You could also write symptomatic for investigation. All of that will ensure that you get a co-test and there isn't an inappropriate C. Next slide. Vaginal discharge and dyspareunia in the absence of vaginal bleeding are rare presentations of cervical cancer, and they're usually due to benign gynecological conditions. So we really want GPs to think about the appropriate use of the co-test, and in a situation like this, it may be clinically appropriate to just order a routine CST. The key words for GPs to help clinical decision making are these: unexplained, persistent or unusual. And if you can apply those three words to either postcoital bleeding or intermenstrual bleeding, and of course for all postmenopausal bleeding, these women will require at least co-test and referral. If a woman has a vaginal discharge that is offensive and bloodstained, and if it's unexplained, persistent or unusual, this woman will require further assessment, irrespective of the co-test result. So if the examination of the cervix is normal and the co-test is negative, these women should still be referred on for gynecological assessment. Next slide. And I've included some of the recommendations here. Remember that if a woman has a single episode of postcoital bleeding, that resolves, the cervix looks normal, the co-test is negative, then she doesn't actually need any further assessment. And of course, she must be premenopausal. Next slide. Women with intermenstrual bleeding may need specialist referral, particularly if that bleeding is persistent or unexplained. Next slide. And really, all postmenopausal women with any vaginal bleeding should be considered for referral and should have an examination of their cervix noted as well as a co-test. Next slide. This is a reminder. Hello?
Hello, Lara.
Yeah, thanks, Tony. Sorry. This is just a reminder for those GPs. Not much has changed from the 2005 guidelines. We still need to apply a test of cure to women who've had a biopsy-proven high-grade lesion. That is essentially now a co-test, and 12 months later, another co-test, and this should be continued until there are consecutively 2 negative co-tests. Next slide. And next slide again, thanks. I'm thinking, Tony, it might be good to skip forward now to the self-collection, if that's okay.
No, that'd be great. And we can read that. We can read those special circumstances in the guidelines.
So let's go through this now in the last few minutes we've got left. We know that 80% of cervical cancer occurs in women who've never been screened or are under-screened in this country, and in fact 6 to 10 Australian women participate in screening at the recommended 2-year interval. And down particularly in our rural regional areas, only 55% of women participate in screening. These stats refer to the previous 2-year screening interval. Next slide. So self-collection is really a pathway that's been MSAC approved, so it has the same rigorous evidence behind it, and it's really to re-engage women into participating in cervical screening. Certainly, the sensitivity and the specificity is comparable to clinician-collected samples if you're using a validated PCR platform, and it sits actually with our laboratory at 94%, which is much better than 89% for the pap smear. Another interesting statistic from the evidence and from the data is that if a woman undergoes just one round of screening and via self-collection, this could actually reduce her cervical cancer risk over a lifetime by around 41% if that round of screening is between the ages of 30 or 40. So even just engaging women who are under or never screened in a self-collection once between 30 and 40 is better than absolutely nothing. And I think that's what's important for the clinicians to understand, that when we're talking about self-collection, we are really comparing women from women to having no test at all to at least a vaginal test for HPV. So the eligibility criteria: women must be 30 or older. They need to be at least 2 years overdue for cervical screening tests, which means really it's been 4 years or more since their last pap smear, or they are never screened. They need to decline for whatever reason. The reason doesn't matter. A speculum exam, and the given is that we offer a clinician-collected sample, and that should be declined. And they need to attend a healthcare setting which offers cervical screening. So it's not a mail-out kit or a home-based test. Women are not eligible if they're pregnant, if they've got symptoms, if they're younger than 30 years of age. Next slide. Certainly, Aboriginal and Torres Strait Islander women, women from CALD backgrounds and rural remote areas are overrepresented in these groups of underscreened and never screened women. Aboriginal and Torres Strait Islander women actually have incidence rates that's nearly 3 times that of their non-ASC counterparts, and a mortality rate which is 4 times that of non-Indigenous women. Next slide. However, there are significant other groups that commonly we do come across in practice: older women, notably HPV vaccinated women, women with previous negative pap smear experience, and others. So have a look at that slide because it'll help you identify these women in your own practices. Next slide. This was a huge pilot that we were commissioned to do. I wanted to just bring home the point that in this pilot, which was run across a number of sites, looking at women who are particularly disadvantaged with low screening participation rates, eligible women took up the option of self-collection in 85.7% of cases, and astonishingly, the adherence to follow-up was 91.6%. Next slide. So the sampling instrument is very important. There's an image of it. It is known as a dry red top flock swab. That's the technical term for it. I'm harping on this because this is the only sampling device that is approved for HPV testing, and the orange top dry swabs that we use for nasopharyngeal swabs are not approved. So it must be exactly this swab. It's a vaginal swab which will be taken by the woman. The sample will contain vaginal, not cervical cells, and it will be sufficiently accurate to allow partial HPV genotyping. Notably, we won't be able to do reflex cytology on the vaginal sample. Next slide. For self-collection, you just need to tick CST or request cervical screening test. Next slide. Tips. It's very important that women understand how to take the sample, and using a visual guide like this, which you can access on our website, to explain how to take the sample. Essentially, the swab will be inserted into the vagina to a red mark, which is on the stem of the swab. That sits at about 8 centimetres. The red mark is there to prevent women inserting the swab any higher. It needs to be rotated at least once, up to 3 times, and withdrawn. There is a soft tip which should be pointed out to the woman. They might like to show her the swab and explain how to take the sample, provide a private area in the practice for the sample to be taken. The a couple of tips. We validated this for all sorts of situations. It's fine if the woman's touched the end of the swab, or she's dropped the swab on a dry surface, or she's inserted it into the vagina but is unsure of how far. It's very important to tell women that taking the swab won't hurt or should not hurt, and avoid taking the swab if it's at the time of the period or if the woman is pregnant. Next slide. Very quickly, the algorithm. Women who are found to have no HPV detected on their self-sample will be invited to rescreen in 5 years. At that time, preferably a clinician-collected sample should be offered. Should the woman decline, that should be documented, and there will be an MBS reimbursement for a self-collected sample. To the far right, unsatisfactory HPV test. These women should be, sorry, we need to go, oh yes, you can pop that slide on, that's fine, doesn't matter. To the far right, these women will be invited to retest in 6 weeks with a self-collect. If a woman has type 16 or 18 detected, you need to tell her that she needs to return to you to organise a referral for colposcopic assessment. At the time of colposcopy, the cervical sample will be taken for the reflex liquid-based cytology. However, women who are found to have oncogenic HPV not 18 detected on their self-sample, those women will actually need to return to you to have a sample taken from the cervix at that visit. So it's quite important that to ensure full compliance with women at the time that you're offering self-collection, that you do talk to them about how, what the different results mean, what sort of follow-up that will involve, and ensure that you document their preferred method of contact, particularly as some of these women are quite vulnerable. Just some information for you. Currently, self-collection is available at no cost to women across Australia. VCS is the only lab that has been approved to process self-collected samples, and we provide this free of charge to all eligible women by bulk billing, and we cover all postal and consumable costs. So if we go to nearly the second last slide, a clear explanation on how to do self-collection and sampling is available actually via News GP, RACGP News GP, and also via our website. Should you wish to send your self-collected samples to the VCS, and that's probably the only option right now, the other one being you could send to your lab, and a lot of the labs are sending on to us, you will need to register with us if you're sending direct to us. And we're happy if you give us a call, final slide, on that toll-free number. You can ask to speak to any one of us. There's 6 GPs and sexual health physicians here available Monday to Friday, 9 to 5, to assist you with any clinical support, education or information you may require with respect to the renewed program and self-sampling. Thanks, Tony.
Thank you, Lara. That's fantastic. So an improvement idea for all of us is to check with our local pathology labs whether they will forward the self-collected specimens onto you or not. We'll have to check local guides about that. Otherwise, register with your service so we can send them directly to you.
And that's right. And on that website, you can order your flock swab. There's a reply paid address that you can basically put on an envelope, put your reply paid, put that onto an envelope, stick the swab in a specimen bag with a request form, pop that all in the envelope and into the post to us. If you think there'll be more than a 7-day delay, give us a call and we'll assist you with transportation. Also, if you've got women who don't have Medicare cards, give us a call. We'd be pleased to assist you with that as well. With those
Fantastic. What a gun service you offer. And that answers one of our questions. The only other question, Lara, was about, I've got a 20-year-old that I did 2 years ago. She's now 22. When she comes in for 2 yearly pap smear, do I say she can come back when she's 25, or do I do the new test on her?
Transitioning women under 25. So if they're under 25 and they have had a pap smear result that's normal or negative, those women will need to wait till they're 25, provided they're asymptomatic, of course. Those women will receive an invitation from the National Cancer Register 3 months before their 25th birthday, inviting them to join the screening program. In women who are younger than 25 who've had a previous pap smear detected abnormality, so those with a previous high grade will need to follow test of cure or referral on to COP, but for the low grade, they should come back in 12 months. So that might mean when they're 23, if she was 22, At that time, she will be offered a CST. If a HPV is not detected, that woman will then be invited to rescreen in 5 years.
Thank you, Lara. That's very clear. And thank you for the information you presented to us so concisely. That saves hours of research and reading for me, and I now have a much clearer understanding of the new cervical screening program. And I'll thank you on behalf of the many people who joined the webinar and those who are going to look at the recording that's available to everybody in the next couple of days. So thank you very much for joining us, Lara, and to those who joined us online. And Sarah, thank you for organising. We'll have another one next month.